Throughout the semester, we've had several discussions about the care of the child, and to always remember that the role of the pediatric nurse is to be supportive of that child as they're in their response to their illness or the disorder, to promote normal growth and development, and to always remember that the care of the child includes caring for the family. A child with cancer has extreme challenges and extreme stressors is placed upon that family, and even with the research that we've done and then improved survival rates and the ability to detect some of these catastrophic diagnoses early on, we still need to remember that the family is in the center of all of this care with the child, and the family's ability to cope to the stressor is very important, and that we as nurses need to assess for those coping strategies. Childhood cancer is really and actually a rare disease. It's less than 20,000 cases of patients under the age 20, and that survival rate has increased over the past 50 years. More of the younger the child that's diagnosed, the most likely that they have a higher chance of survival from the cancer. So what are some reasons that my child may get cancer? The most likely theory is that there's been some kind of genetic alteration in the cells as they proliferate. The risk factors are not the same as adults. You all can probably list some risk factors for cancer, or some preventative things. So thus, since the risk factors aren't the same, such as sedentary lifestyle, smoking, poor diet, the prevention is not the same. So the signs and symptoms are much more general also than specific with my pediatric patient. My child's going to present with a fever. They're going to present with general malaise. They may have some pain ailments, some pain complaints, but they usually tend to be minor, and these minor complaints will present for a while before the parent brings them in to have the child evaluated. Some diagnostic tools that you might see ordered. Your CBC, we're looking for the composites of the blood cells, the type of white blood cells, coagulation studies, we're getting an electrolyte panel, a lumbar puncture or spinal tap, bone marrow. Those are diagnostic procedures. Imaging would include a CAT scan, some PET scans, and then evaluation of the type of cancer or the stage of the cancer would be your biopsy. Treatment modalities include surgery, chemotherapy, some radiotherapy, immunotherapy, or bone or blood marrow transplant. So surgery, the main goal of that is to remove all of the affected tissue or the organ to take the cancerous area out. The chemo is the primary form of treatment, or it can be the primary form of treatment, or it may be in addition to surgery and radiation. As the pediatric nurse, there's special certifications to be able to deliver chemo to the patients, and considerations or thought needs to be given on the handling of the chemo agents. Once you're certified in the ability to deliver these medications, you will learn all these special things. There's policies within your organizations on how to administer the medications, how to flush the ports that the child has, how to clean the ports. The patient may have a central line or a surgically placed port to receive the chemo. The radiotherapy is used for curative or palliative purposes, depending on what the goal is. The immunotherapy, these are biological response modifiers, and they use the body's own immune system to fight the cancer. This is an up-and-coming area in research. It is an up-and-coming way to treat the cancerous cells so that when they proliferate, that when new cells proliferate, they aren't mutated, they don't have the cancer. Then your transplant, these are patients who have cancer and will require high doses of chemo to replace the dysfunctional bone marrow. The cells can also come from cord blood. So let's talk about some emergencies in regards to my pediatric patient with cancer. And there's a couple that your book goes over. We've talked about some treatment, we talked about the effect on the child and the family. Let's talk about some emergencies that you as the nurse would want to be looking for. These are the thoughts of what's the worst thing that can happen if my child has cancer? What's the poorest outcome? What am I looking for? How are my interventions going to guide my care so this doesn't happen? So one of the oncological emergencies is something called a tumor lysis syndrome. This can be a result of a rapid release of contents such as the malignant cells break down, they lysis. The patient can also experience hyperkalemia. Hyperphosphatemia are some examples of some things that can happen with the tumor lysis syndrome. Another emergency is the hyperleukocytosis. This is where I have a WBC count. I think your book gives you the number of 100,000. Because of the hyperleukocytosis, the blood becomes very thick, very viscous. We've talked about this in regards to polycythemia, but here it's because of the WBCs are elevated. So we can have capillary obstruction, we can have microinfarction, we can have organ dysfunction as I'm trying to perfuse different organs. Patients will often experience some respiratory distress and cyanosis with this. The patient can also, another example of an emergency is the superior vena cava syndrome. And this occurs if lesions or tumors are located in the chest. These tumors can lead to airway compromise and respiratory failure. And management of this is airway. So my airway is my priority. And then spinal cord compression. These are the same issues as the superior vena cava syndrome, only that there's compression on the cord. And this compression can affect mobility, it may affect respiratory efforts, it just depends on where the compression is occurring. So you'll see high doses of steroids ordered for these patients to decrease inflammation, and typically the patient will report some kind of pain, and that's the first indicator. Let's talk about some side effects that can occur because of some of the treatment. So infection, that is one of the main side effects of some of the treatment. So we're trying to take care of this child, we're trying to support the family, but sometimes our interventions can lead to other sequelae or consequences that become a concern. So a child with a fever that has an absolute neutrophil count of less than 500 is at risk for an overwhelming infection. So what would be some nursing considerations? Some nursing considerations would be strict hand washing, making sure this child is not around a lot of visitors. If the visitors come in, they need to not be ill. We need to make sure my child's immunizations are up to date. The child may even be put on reverse isolation. I need to make sure that the child is not exposed to any of the pathogens that are in the hospital environment. So it really comes down to the nursing care of that child to make sure that they don't get an overwhelming infection. Hemorrhage is also another side effect of some of the treatments we give. Before we were able to transfuse just the platelets, hemorrhage was actually the leading cause of death with some of the cancers that the children have. Anemia, that can be a consequence of some of the suppression drugs, some of the chemotherapy drugs that we give. We need to allow the child to regulate their activity on which they feel comfortable. We don't want to limit their activity, but if they say they're tired, they're tired. And then ulceration, some mouth sores. That's very common stomatitis with some of the chemotherapy agents that are given to the child. With your adult patient, you probably have seen, whether it's been an oncology patient or for other reasons, if they get the mouth sores, something called magic mouthwash that is used. And we do use that with children who can kind of swish the elixir in their mouth and spit it out. But what the difference between what the pediatric magic mouthwash is and an adult is that the pediatric magic mouthwash contains no lidocaine. It is half Benadryl, half Maalox. And what the Benadryl does is kind of help to shrink, because the antihistamine properties kind of help to dry out and shrink the sores in the mouth. And then the Maalox just coats it so it's not as uncomfortable to the child. We don't give the lidocaine for two reasons. One, we don't want the child to swallow the lidocaine, and then the absorption of the lidocaine through the buccal mucosa may cause some cardiac dysrhythmias. So we're really not able to use the same medication for my peds patient and my adult patient in regards to these mouth sores. So you as a nurse just need to be careful when you're administering it. If it's ordered through the computer, it'll just say magic mouthwash. If pharmacy doesn't pick up that it's a peds patient, you may have something delivered to the floor that could cause an issue for your child. Another treatment we have for children with cancer is an allogeneic bone marrow transplant. This involves matching a donor that's compatible with the child, with the recipient. The cells are aspirated from the donor and given to the patient, to the pediatric patient. One of the issues and one of the challenges is that there's a limited number of suitable donor matches, and the most common side effect of this process is rejection. Umbilical cord blood stem cell transplant is another intervention that we can have for some of our children. You will see, and you've probably discussed this with your OB, the cord blood registry is becoming a more and more common practice for parents to save that cord blood should the child ever need that cord blood, because you're giving the child their own cells, but they're healthy cells. They're cells that haven't been differentiated yet, and so they're able to produce healthy cells. They're found in the circulation of my newborn. It could even be that this cord blood could be used as a match if it matches a sibling. It's just a nice source that is usually better tolerated by the patient and or a sibling. Autologous bone marrow transplant may be yet another intervention you see in the series of treating your child. This is where we use the patient's own marrow and we collect it hopefully from a disease-free tissue rather, and it can be frozen. Sometimes it's removed. The patient's bone marrow is, if there are malignant cells, that bone marrow is treated, and then the healthy bone marrow is reimplanted into the patient. Once again, it's the patient's own cells, so the patient tends to do better with the process. Peripheral stem cell transplantation is a different type of autologous transplant. This is where the patient, we stimulate the production of the number of stem cells and then collect those stem cells through a process with apheresis. The stem cells are then separated out from the whole blood. The remaining blood cells and plasma are given back to the patient, and then we save the stem cells. They're frozen and saved for later transfusion for the patient. But once again, it is the patient's own cells, so the process only involves the patient. The likelihood of rejection is lower because it is the patient's own cells. So far, we've talked about the importance of supporting the family during the process of the child being treated for cancer. We've talked about some different treatments to include chemo, radiation, some transplants, and some different types of transplants. So let's talk about some of the more common childhood cancers that you're going to see. Let's start with leukemia. This is the most common form that you're going to see in your pediatric patient. The survival rate for leukemia is about 80%. There's some statistics listed up there for you. The peak is between 2 and 6 years of age, and it's more frequent in my male population after the age 1. The term leukemia describes a broad group of malignant diseases of the bone marrow and the lymphatic system. It's a very complex disease. The classifications are a little bit complex, but the two general forms in regards to my pediatric patient are acute lymphoblastic leukemia, or ALL, and that's the one that has the 80% survival rate, or acute non-lymphoid or leukemia, or AML. There is some connection between genetic disorders and the chances of my child developing a childhood leukemia. We know children who have trisomy 21 have a 20 times greater risk for developing ALL. Children who have more than 50 chromosomes have, on the leukemic cells, have the best prognosis. And the specific translocation of the chromosomes, the specific issue with the chromosomes genetically can affect the prognosis. So there is some genetic component to the process. Leukemia, a good description of the pathophysiology that occurs is an unrestricted proliferation of immature white blood cells in blood-forming tissues of the body. Although it is not a solid tumor, you still have some of the same neoplastic properties that occur with cancers that have solid tumors. So the results from these pathological changes, or the pathology of it, and clinical manifestations are caused when there's an infiltration and replacement of any tissue in the body with these non-functioning leukemic cells. Leukemia is an overproduction of white blood cells. Most often the leukocyte count is low. It's the immature white blood cells that has the overproduction. They'll have immature cells or blast. You have a nice flow chart in your book that kind of goes through the pathophysiology and what can occur when the leukemic cells infiltrate these organs. So these leukemic cells can depress bone marrow production. They deprive normal cells of essential nutrients that they need for metabolism. And there's three main sequelae, three main consequences that occur when there's the bone marrow dysfunction. You're going to have anemia because they have decreased erythrocytes, infection from neutropenia, and bleeding because of the decreased platelet production. So once again, if you understand the normal function of my bone marrow, now there's an issue, so what would I expect my patient to present with? Because the invasion of the bone marrow, or because the leukemic cells invade the bone marrow, it can weaken the bone and my child's more prone to fractures. The most common or the most classic signs of leukemia are the result because of the infiltration of those bone marrow. So they're going to include fever, pallor because of the anemia, I'm tired, my appetite, anorexia, I'm going to be down, hemorrhage, usually in the form of petechiae when I'm looking at the skin. My child may complain of bone and joint pain, and that bone and joint pain may be what brings the child in initially. If I have neutropenia, even just my normal flora, my normal bacterial flora can become these aggressive pathogens. So any break in the skin, any compromised in the skin, any impaired skin integrity can be a potential site for infection. Frequently, my child may complain of just very vague abdominal discomfort, and that's where there's inflammation in my GI tract because of the intestinal flora that is growing. The diagnosis of leukemia is usually thought about or suspected from the history that I'm getting from the patient and their family, from their clinical presentation. I do blood work, and I'm going to see an elevated number of those immature leukocytes. I may see low platelet counts. The definitive testing or definitive diagnosis processes would be the bone marrow aspiration or a biopsy. Once I have the definitive blood work, your child will now receive a spinal tap to see if there's any CSN and CNS involvement. That's really kind of a rare complication, but once again, once we have that diagnosis, we now want to see what organs are being affected. The interventions for therapeutic management of leukemia would include my IV chemotherapeutic agents, and maybe intrathecal, which if I had CNS involvement, or maybe a stem cell replacement. My child who is being treated for leukemia goes through 4 different phases of the treatment, which are outlined in your book. The introduction therapy is where my goal is to have the child be put into remission, meaning that I'm no longer having the production of the leukemic cells. I then try to, if necessary, give the CNS prophylactic therapy or the intrathecal chemotherapy. Sometimes, even if my child does not have it in their cerebral spinal fluid, I may still have a child get this prophylactically if the type of leukemia is indicative of that could be a problem. So sometimes we'll do it prophylactically. The intensification or the consolidation therapy is to get rid of any residual leukemic cells and prevent any resistant leukemic type cells that might still be there. And then the maintenance therapy. The maintenance therapy can be 2 to 3 years. So we talked about having a good prognosis. We talked about that, the younger my child, the better that prognosis is. But this is something that we now view this more of a chronic issue than an acute issue because of the length of time and the follow-up that the child will need to endure. If my child does receive a stem cell transplant for the chemo, I need to be aware of some risk. And the infection due to my suppression drugs given before transplant can also be a risk. The chance of the child rejecting the stem cell, we've talked about that, but it's that overwhelming infection that I'm concerned about. After receiving my stem cell transplant, I have about a 60 to 70% cure rate. So the statistics are good for the child that is able to endure this process. So although we talked about that I have an 80% survival rate, let's talk about if I have the stem cell transplant and if I relapse during that process, my outcomes probably are not going to be favorable. Some things that affect my prognosis is what my initial WBC count was, how old I was, the type of leukemia I had, my gender, and my age, and the karyotype. Some of the chromosomes just have some of the chromosome defects or the genetic predisposition just historically have a poor response to any of our treatments. Let's talk about the nursing care or nursing considerations for my child with leukemia. My assessment. My head to toe needs to include a good skin assessment. I need to get a good baseline for my cardiac, my respiratory, my belly, so I can see if there's any changes in relation to the child's disease process or the interventions that I am providing for this child. Some nursing diagnosis would be in relation to the disease process, family support, and the child's response to the illness. The care is directly related to the type of treatment my child is receiving. So if I'm receiving chemotherapy agents, I'm concerned about infection. I'm also concerned about hydration if I'm having a poor response to the chemo. If I've got sores in my mouth and I'm vomiting and I'm having diarrhea, then one of my interventions would be one of my concerns would be fluid volume deficit, and my interventions would be revolved around that. So the care is directly related to my child's treatment plan. I need to remember to include the child and the family when prepping for procedures. I need to consider pain management for this child and then prevention of complications from the treatments. Some nursing diagnoses that would apply was risk for injury, risk for fluid volume deficit related to the nausea and vomiting, altered nutrition, impaired skin integrity, altered family process, and then fear related to the diagnosis itself. Another type of cancer I may see in my pediatric patient come under the classification of lymphomas. These are a neoplastic disease that begins in the lymphoid system and then metastasizes to non-nodule sites. The two that your book focuses on are Hodgkin's disease and non-Hodgkin's lymphoma. My Hodgkin's disease I see more commonly in my patients age 15 to 19, non-Hodgkin's in my younger children, 14 and below. My Hodgkin's disease is a neoplastic disorder that begins in the lymphoid system. It often spreads to the spleen, liver, bone marrow, lungs, and other tissues. So depending on where it is spread, now the dysfunction in those organs is going to affect the clinical presentation I see in my child. It's characterized by painless enlargement of lymph nodes. We've talked about from on day one that when I palpate my child's lymph nodes, they tend to be larger in my younger child because I have an immune system that's not that smart, but they shouldn't be painful. But if I have a lymph node that now is larger than it has been, and it's not painful and there's no infection proximal to the site, I now become concerned because Hodgkin's disease, one of the characteristics is painless enlarged lymph nodes. The lymph nodes are enlarged, they're firm, they're non-tender, and you're able to move them. They're movable, but they're not painful. Management for Hodgkin's disease could be chemotherapy, radiation. The chemo can be done alone or with the radiation. The prognosis just depends on where, if it has spread or not. Nursing considerations, we always need to make sure we're prepping the child for any procedures. The side effects will be dependent on what the treatment is and to provide support for the family and the child. Non-Hodgkin lymphoma, we see this in about 60% of our pediatric lymphomas. The disease is more diffuse. By the time it is already spread, it is usually already spread rather before the child is actually diagnosed. Some clinical manifestations, it just depends on the anatomic site and the extent of involvement. You may see some of the same manifestations as Hodgkin's disease, but it's not usually just a single symptom. It usually metastasizes to the bone marrow. We may have some CNS involvement, typically like of our leukemias. The lymphoid tumors can be compressed on various organs. It may cause intestinal airway obstruction, cranial nerve paralysis, or spinal paralysis. Your book on page 830 has a nice chart on staging just for you to know, not for you to be tested on, to show you how we stage the non-Hodgkin's lymphomas. So we talked about that the diagnostic evaluation is very similar to the Hodgkin's disease. The therapeutic treatment is we have aggressive use of the radiation and the chemo because this is widespread. The prognosis is really determined if my younger child is going to have a better prognosis, how the child responds to the treatment, and the earlier that I can get the treatment in. My nursing care my child is getting very intensive chemotherapy. So really my care is directed towards managing the signs and symptoms of that chemotherapy, which we have discussed. Another presentation of cancer in my pediatric patient is my CNS tumors. They account for about 20% of my childhood cancers, but these tumors are very difficult to treat, and the survival rates are very poor for my pediatrics. The evaluation or the diagnosis of the brain tumors are related to the location and size and the child's age. The presenting clinical signs can be varied. Your book has a nice table in it that breaks up the clinical manifestations. They could be something as general as a headache, but these headaches are recurrent, they're becoming worse. It's usually in the front or the occipital areas. They are worse as the child wakes up, and they kind of dissipate a little bit throughout the day. If the child is bearing down, like during a bowel movement or coughing or sneezing, they may say that the headache's increasing. Your patient may have vomiting with or without nausea, and not necessarily connected to a feeding time. The vomiting may become more projectile, which is telling us what? That there's an increase in ICP. The vomiting may be more severe in the morning, once again because of the ICP, or if the child's just moving or changing position. The parents may notice neuromuscular changes rather in the child. They're becoming more clumsy, they're losing their balance, maybe a change in fine motor control. They're either hyporeflexive or hyperreflexive. They had a negative Babinski sign, which was appropriate for the age, and now it becomes a positive Babinski sign. Behavior-wise, the parents may report to you that the child's more irritable, decrease in appetite, thus a failure to thrive, a little bit more lethargic, or they're staring, they're having jerky movements, which would, to us, may indicate some seizure activity. They may have a head tilt, they're not able to hold their head upright. The patient may complain of some visual defects, either the visual fields are not where they need to be, those cardinal fields that you guys learned in health assessment, or maybe when they're looking at something, it's grayer, they're not able to see the whole object. As far as vital signs, they could have a decreased pulse, they could have a decreased respiratory rate, they might have an increased blood pressure, they may have a hard time regulating their body temperature. We talked about seizures, maybe cranial enlargement. If I'm an infant and my fontanelles are still open, my anterior fontanelle may be tense or bulging. The sutures may separate. I may complain of nuchal rigidity as I move, try to touch my chin to my chest or bring my knees up. It may be irritated. And when I look at the retina, I may have papilledema when I do a fundoscopic exam. Treatment might include surgery, depending on where the tumor is, depending on if it can be removed. Oftentimes, even with non-malignant tumors, the residual from removing the tumor, and we often have to because of the ICP and the compression on the brain tissue, the residual, the consequence for removing it is the child now has severe delays or negative effects from the surgery. So surgery might be one approach, radiation might be one approach, and chemo. There might be a combination of all three. So what's the nursing care of this child with a CNS tumor? I'm going to prepare the family for any diagnostic or operative procedure. Afterwards, the child may have drains coming out of the skull to drain, bloody drainage. We may be monitoring ICP. This child may be intubated. They're going to be in the ICU. There's going to be lots of lines attached. So it's a very traumatic effect for the parents with all this happening to the child post-surgery. or any of the diagnostic things that we need to do, in addition to knowing that the prognosis is probably not going to be what they're wanting. We need to make sure we have a good baseline, so if there's any changes in my neurological function, I can pick up on that. Postoperative care, once again, depending on what the intervention is, that's going to drive my care, and then support for the child and the family. A neuroblastoma is your most common extracranial solid tumor that you're going to see in your pediatric patient. The majority of the tumors we see on the adrenal gland. Some other places can be the head, the neck, the chest, the pelvis. Metastasis has probably already occurred before a diagnosis is made, which is why the earlier the diagnosis and the younger my child is, the better the prognosis is going to be. The child's age and the stage of the disease at the time of the diagnosis are important prognostic factors. There's a little shaded box in your chapter that tells you how we stage neuroblastoma. Once again, not for you to memorize for the test, just for you to be aware that there is a process. The survival rates for a child younger than age 1 is about 80% and less than 50% for a child that is over age 1. Another solid tumor is one that we've already discussed. We did this when we talked about GU, and that's Wilms tumor. It's a tumor of the kidney. It presents with a painless abdominal mass. It may influence blood pressure. It may influence my ability to produce erythropoietin. I may have blood in the urine. What we need to know as the pediatric nurse is if a Wilms tumor is suspected, we do not palpate that abdomen. We need to be careful when we move this child, when we bathe this child. Surgically, they go in and remove it. The tumor is encapsulated, and as long as it stays encapsulated, the prognosis is good.